So magnesium, is rarely people talk about magnesium, and we'll try to elaborate a few things. And the most important thing about magnesium that is the uniqueness of its reabsorption. Most of the nutrients and solutes, as you know, are like reabsorbed in the proximal tubule of the kidney, but the magnesium is not. Like 60 to 70%, in fact, is being reabsorbed in the thick ascending lobe of Henle and exactly between the cells that we call it paracellular. And 25% is in the proximal tubule, and 5 to 10% only is being fine-tuned in the distal tubule. We will touch base about this a bit in the coming slide. What factors that could affect the magnesium reabsorption? The magnesium itself. So if magnesium in the serum is a bit high, this will inhibit its own reabsorption. And what could inhibit as well reabsorption is hypokalemia, phosphate depletion, metabolic acidosis compared to metabolic alkalosis, and all of these things supposedly happening at the level of lobe of Henle, but the mechanism is not very well understood. The thiazide, we know that thiazide will cause hypomagnesemia. And the same thing, the murine knockout, of their TRPM6 co-transporter or the channel. They do have hypomagnesemia. So the thing is that thiazide is affecting the same channel, that TRPM6, in the level of distal tubule. That's why they cause hypomagnesemia, as well as the Gentleman syndrome. It's in the same way of the mechanism. As we have potassium sparing, we have magnesium sparing. So amiloride is a magnesium sparing diuretic. So if you're using thiazide or lobe diuretics that cause hypomagnesemia, you can change it to amiloride. Magnesium is intracellular cation. Whenever there is a drop in ECF magnesium, the exchange between intracellular and extracellular will take time. That's why any donor drift a bit of magnesium would cause, in fact, hypomagnesemia. And usually hypomagnesemia is associated with hypokalemia and hypocalcemia as well. The thing is, hypokalemia we'll talk about in a minute. Hypocalcemia, in fact, because magnesium is crucial for PTH function and secretion. So both function and secretion. Just remember this. Small drop in magnesium, in fact, will cause PTH resistance. And more drop of magnesium will inhibit PTH secretion. That's why hypocalcemia eventually is happening. The causes of magnesium depletion are a couple of ones, starting from the GI loss, and this is a bit common. Whenever there is like chronic illness causing diarrhea, malabsorption, would cause hypomagnesemia. Acute pancreatitis, because it chelates magnesium as it chelates calcium in the process of saponification. Medications, PPI, and some of the genetics. Renal losses, diuretics, lobe or thiazide, antibiotics, aminoglycosides. Remember this, aminoglycosides is a reason for hypomagnesemia many times. Calcineurin inhibitors, tacrolimus, cyclosporin, cisplatin, antibodies targeting epidermal growth factor receptors like cetuximab and panitumumab and etc. Volume expansion, alcoholism, hypercalcemia, tubular dysfunction, post-kidney transplant. Most of the time, CNI are on board, and they're the reason most of the time. Some genetics, as we mentioned, Barter, Gentleman, and etc. GIT loss is, it could be either from upper or lower. and more commonly due to diarrhea than vomiting. And the reason is the concentration of magnesium in diarrheal fluid is much higher compared to its concentration in the gastric fluid. And common causes, as just we mentioned this, and remember, small bowel bypass surgery is a reason as well. Acute pancreatitis, we mentioned this. Proton pump inhibitors. In fact, this is a common reason for hypomagnesemia, and it does not cause renal loss, it causes GI loss. It's working on the same receptor. There is this receptor is TRPM6 is as well there in the in the intestine, and if it is affected by PPI, this would cause hypomagnesemia. The urine magnesium loss can occur by a variety of either acquired or intrinsic mechanism, as we mentioned below, anti-azide diuretics, and these medications, we mentioned most of them anyways. Hypoparathyroidism exists in most hypomagnesiemic, hypocalcemic patients. What does this mean? If you have a patient who's having hypocalcemia, because of hypomagnesemia, most of the time, their PTH will be not functioning well, either resistance or there is, hypopara. When you give them parenteral magnesium, and you measure the PTH, you will be surprised that the PTH is back to its normal level, or if it is not low to start with, it's going back to its function. There's something very unique about magnesium. It's called normal magnesium depletion, i.e., there is, no hypomagnesemia, literally, but patient is hypocalcemic. When you go and search for, many reasons, you might fail to find the reason, but when you replace magnesium, then you see the calcium will be corrected. And but these patients usually they have hints to tell you that there is depletion in the magnesium, like alcoholism or diarrhea. 40 to 60% of cases of hypomagnesemia, they have low potassium. The reason is, in fact, whatever is causing low magnesium might be causing low potassium, like diarrhea, for example, or diuretics. But more importantly, that I'll take you to the right lower corner, to this connecting the tubule area, where the connecting the tubule is just after like distal convoluted tubule and before going to the collecting duct. There is a special cells here, and which is responsible to get rid of potassium through what's called the ROMK channel. And this ROMK channel, in fact, is regulated by intracellular magnesium. So if intracellular magnesium level is fine, it means that this ROMK is guarded and is not being allowed to shed off lots of potassium. But if it is not there, if the magnesium is low, this will cause potassium leak and resistance to whatever your potassium therapy. You're giving potassium from one end, parenteral potassium, oral potassium, but the patient is losing it because magnesium is not guarding that ROMK channel, causing it leaking potassium and causing your hypokalemia refractory. How would we treat? It depends on the symptoms. Patient with severe symptoms, like there's tetany, arrhythmias, or seizure. Intravenous magnesium is essential. So patients should have continuous cardiac monitoring anyways, because magnesium as well is linked to the excitation process, and these patients should be on monitoring. So if your patient is hemodynamically unstable, you're dealing with a patient like an ACLS patient. You need to give them a bolus of magnesium over like 2 to 15 minutes, 1 to 2 grams. Like like as if you're dealing with arrhythmias. So your patient is hemodynamically unstable. You'll give 1 to 2 grams of magnesium sulfate over 2 to 15 minutes. If your patient is stable, you give this dose, but in a slower range or a slower rate, like over not 1 minute, maybe 5 or even 60 minutes. It depends on your patient situation and the level of magnesium as well. What about if your patient does not have emergency? So you need to replete their magnesium level by giving 4 to 8 grams of magnesium sulfate over 12 to 24 hours. In normal magnesium patients, there's no guide. We don't know what is the target magnesium. The previous ones, you know that when you reach like 1 milligram or 0.4 millimole per liter of magnesium, then you could say this is the time that I need to stop replacing and repeat after and see. But normal magnesiumic, whenever you give magnesium, the cells are depleted of magnesium. Magnesium will go inside the cells. You need to repeat, this dosing like over 3 to 5 days to make sure that cells are fully saturated. If there is renal impairment, EGFR below 30, you need to go like 50%, dose reduction, avoiding magnesium toxicity. This is an important slide classifying like hypomagnesemia to severe below 0.4, moderate 0.4 to 0.6, mild 0.7 to 0.8. So we're talking about the repletion, not for the patient that is unstable. We stabilize the patient, then we are in the repletion stage right now. So in severe ones, you give 4 to 8 grams over 12 to 24 hours. Moderate, you give half of this dose, 2 to 4. If it is mild, you give like only 1 to 2 grams. And you repeat as needed. The testing usually over like 6 to 12 hours testing. And if you have renal impairment, like 50 to 30 ml per minute of EGFR, it depends. If your patient is symptomatic, you deal with him as if he's having moderate. If there is severe, you deal with him as if he's having a moderate. You don't give 4 to 8, you give 2 to 4. Asymptomatic, you don't need to give, IV, you give oral. And you need to check watch for toxicity of magnesium, facial flushing, decreased tendon reflexes, hypotension, or AV block. The best, by the way, in replacing magnesium is not the IV one. We mentioned there, you give IV, what happened? The magnesium increased, then it goes to the kidney gets rid of it. But the oral ones, the long-acting ones are the best, in fact. You remember that we use magnesium sulfate for prophylaxis and agonist seizure in eclampsia, and the dose is huge. It's like 4 to 6 grams over 15 to 20 minutes, and this should be IV. You could give it IM anyways, but IM is a bit painful. And if you have a patient with renal impairment, you could give the loading dose safely without reduction of the dose. And the maintenance dose is 1 to 2 grams, and with those who have good renal function, with low EGFR, you don't give like 2, you go with 1. And again, you watch for patellar reflex. Respiratory rate should be more than 12. Urine output should be more than 100 ml over 4 hours, like 25 ml per hour. And the question is, do you need to do the level of magnesium? Well, the guidelines tells you if you're good in physical exam. Yeah. When I say good, it's really good. You follow those, you don't need to do it. And if you have toxicity, the antidote is the calcium gluconate. This is the magnesium.